So first, thanks very much, Manos and Manos, for having me here. It's my first time in Athens. I'm very excited to be here, and what a great day. I mean, I came here, I was here at 7:30. I haven't left hardly, and so it's a wonderful, wonderful day of the shoulder. So these are my conflicts, and then my topic is on biology, and try to give you some things that maybe can help. Alex gave me a great introduction because our problem is that despite all of our biomechanical advantages that we've had, our healing rate has not changed in the rotator cuff. From Neer's work through Matson through now, they heal exactly the same. So we need to change this. And how do we do this? I think it's all biology. So we're going to talk about several things, I think, today. One is anchor sutures, one is biomechanical, other biologic considerations, and then something we as orthopedic surgeons rarely think about, nutrition. So there are four biologic areas. One is anchor venting. Alex alluded to this. I think however you want to do this, one of our mentors, Steve Snyder, talked about the crimson duvet. We have to get stem cells from the marrow into our cuff. And we lost that with anchors. Second is about balancing the shoulder. We had a very nice session on supracapsular reconstruction. That's all about balancing. Bioinductive implants is a coming thing. It's just getting started. It's going to improve over the years. And then nutrition. So anchor venting, does it make a difference? So this is a vented anchor on the top and a non-vented anchor on the bottom. And if you don't know whether your anchor is vented or not, I suggest you find out. We did a randomized study when this first came out. This was the first vented anchor on the top to see if it made a difference. It was an ultrasound study. We actually made a second crimson duvet deep vent into the marrow about 5 millimeters away from the anchor to see if it would make a difference. And so this was a published study, but our results showed that the tendon above the vented anchor at 6 weeks was already 1.2 millimeters thicker than above a non-vented anchor. And this was statistically significant, less than p.05. Both surgeons, we thought, when we looked at the ultrasound, as you see on the right, measuring the depth, thought it was better alignment on the rotator cuff. It definitely provided increased healing. The trephination holes that we made actually looked exactly the same as the vented anchors. So again, if you use all suture anchors or you use plastic anchors or metal anchors, you should make sure they're vented so you have marrow access. The transosseous equivalent, the new tunnelers that do that, will create large holes and let those stem cells access the cuff. So I think that's a good idea. It's a back to the future concept that probably is sound based on biology. What about biomechanical advantage? You heard some people talk today about you couldn't get the head down. We have a very nice series of x-rays showing that we can. But step number one to remember is that the inferior capsule in these superiorly migrated heads is often contracted. And if you don't release that capsule, as you see here, you're never, ever going to get the head down. And in fact, biomechanically, you'll pull your tear apart when you try to put it back together on top. So you have to do that release, as you see here, in order to get it back. So what does that look like? Well, if you look here, we've done our release. We've released the coracohumeral ligament, both bands, off the base of the coracoid, as you see to your left. And then if we pull down on the head and put just a little bit of traction, that cuff just wants to come right back together. So balancing the shoulder, in the bottom right, you see a picture of the biceps used as an SCR. I think if you can repair good tendon, that's your superior capsular reconstruction because the capsule is with it. If not, an autograft is probably better. I did not have good results with my dermal allografts, and so we don't use those anymore. Number three, bioinductive implants. These exist now. Something to stimulate blood flow and tendon cells into the tendon. So this induces remodeling and revascularization. We have one, I think it's just one step. I think better things are coming, but this was the one step that we studied. And so the one we use right now, Des Bacher developed, and it's highly porous type 1 bovine collagen, very purified. And Steve Arnosky, who taught us how to repair the meniscus because of the blood supply, was actually the designer. So originally they brought it out for partial tears. I don't use it for that, I'll be honest with you. I think my partial tears do fine, and it's not worth the expense. But what we wanted to look at was large and massive tears, especially the majority of my practice is revision cuffs. Very rarely do I see an acute primary tear, which is where Ed and I's disagreement comes in because I'm doing revision cuffs and he's doing reverse shoulders. And so, but this is how we do this. So it's a prospective, we did a proof of principle study, and we looked at ultrasound at 3, 6, 12, and 24 months and an MRI around 1 year post-op to see. And these were all 2 or 3 tendon tears. The majority of them had had surgery before that had failed. B-share lateral didn't make any difference. The rotator cuff repair was performed however we usually do it. I am an anchor minimalist, so the majority of these, no matter how big the tear, was 2 anchors, oftentimes 1 anchor to put it all back together. The patches were applied as you see right there. I do not use the peak anchors. I think anything you can't see on x-ray is bad if it doesn't go away. And then we didn't change our post-op rehab at all. We had 23 patients in our initial study. We had 2 that dropped out, and so that left us with 23 of our first 25, 11 large, 12 massive, male, female about the same. 16 of these were revisions, 7 primaries, and we didn't have any difference in results. So we had a 96% healing rate. 96% healing rate in these patients. 22 out of 23 healed. 91% were considered successful outcome. 1 developed arthritis about 4.5 years out. No adverse reactions to the patch, no different large and massive, and no difference in primary revisions. And one of the things that was very impressive was that the ultrasound thickness was 7 millimeters when we looked at them at a year. Our MRI at 1 year was 5 millimeters plus or minus 1. And again, no difference across the board in how it did. 2 failures, 2 people that went back, failed. 1 was a massive tear, 3 tendons. The supraspinatus did not heal. Subscap and infraspinatus healed. He was very happy with his shoulder. It was basically a balanced partial repair and declined another operation. The other lady progressed her arthritis. She was Hamada 3 when we did the repair, and that progressed on. So we went back in to do a reverse shoulder. I've been asked subsequently, why didn't I do an anatomic total shoulder since the cuff was okay? I had no idea if the cuff was going to really be okay or not. I mean, I fixed it and put a patch on it. So as far as I was concerned, at her age, I was going to do a reverse. It looked good on ultrasound and MRI, but the muscle had atrophied and the arthritis had gotten much worse. This was a biopsy. The radiologist read it as tendon, normal tendon-like tissue. That's about as good as we can do, and that's where there was nothing there. That was all where the patch had turned into her capability. So overall, 96% healing rate. My buddy Rick Ryu always says, well, you have to tell him what your healing rate is on those tears prior to using the patch, and it was 85%. So I increased 10% simply by adding the patch to a structural repair I already did. No adverse reactions, so it's a promising step to biologic enhancement. Number 4, nutrition. There's some things we need to think about. 1, vitamin D. You're dealing with folks that look like this on your right. They're not the healthiest people in the world. Mine are either obese in the U.S. or very thin. They're vitamin and nutritionally deprived. And so what can we do? Well, we test our vitamin D and put them on vitamin D and calcium ahead of time. Number 2, doxycycline is a terrible antibiotic, but is a great MMP3 inhibitor. MMP3s are what prevent your rotator cuff from healing. So we put them on 100 milligrams twice a day for 3 to 6 weeks. In addition, if you're doing a revision, it also kills P. acne, so you get an added benefit. And if you're worried about prior anchors and you're not taking them out, if you add rifampin, it potentiates the doxycycline going into the bone and killing any infection. Juven HMB is an Ensure type product. The wound guys use it, and girls use this all the time to speed wound healing. And so we did a study on this as well, and again, found another millimeter of thickness at 6 to 8 weeks if they took this nutritional supplement every day for the 6 to 8 weeks. We had vitamin C because it helps collagen cross-linking, and with all due respect to our anesthetic colleagues, no anti-inflammatories for at least the first 4 weeks. That is a proven fact that it slows down tendon healing. So opioids slow down tendon healing, anti-inflammatories slow down tendon healing. Patient may have to tough it out a little bit. Ice is a wonderful thing, but they should not do anything that affects their healing. So we test this, sorry, let's go ahead, there we go. And then experimental substances. What about other things? Platelet-rich plasma, using the bursa as a part of this, BMAC or adipose-derived stem cells, and then off-the-shelf substances like amniotic derivatives. Just a couple of quick comments on it in the time we have left. Platelet-rich plasma, there's no effect at the time of surgery. We need a better substrate to put it in. That'll start releasing it around 6 to 8 weeks. If we can't have that, then Peter Millett has shown that if you inject leukocyte-rich PRP into the cuff at 3 months and 6 months, you actually will get a good response of healing. There we go. Let's back up. Bursa, Mazaka has shown us that the cells for healing actually come not just from the marrow, but also from the bursa. I've spent 30 years preserving the medial bursa and not doing a cautery on it. So when you see lots of cauterization in the subacromial area, yes, you have to see, but you're also killing one source of your nutrition, and so you probably want to leave those alone. We probably ought to be sewing some of the bursa into the tendon instead of excising it like we were all taught when we were younger. Stem cells, BMAC and adipose-derived stem cells, there are no definitive studies showing good results. Mazaka probably has the best research, and although he's shown that they can get there, very little, but I think this is a huge area of research and holds wonderful promise. This is just one study showing that there was no effect, and then there's another study, as you see here, from Korea showing that maybe a little bit of an effect with with bone marrow-derived stem cells. So in conclusion, venting somehow, get the marrow involved, however you want to do it. Balance your shoulder with reconstruction on top and release on the bottom. Use something to induce biology. Check your nutrition ahead of time, but I think the future is all biology, not more or better anchors. Thank you.